How are you guys? Now, this is a continuation of the video presentation we did on the subjective assessments, the pointers, the fact that we can gain from subjective assessment to begin to make us think that our patient might be having sacroiliac joint dysfunction. Let's do a quick summary. We said the pain will be below L5. The pain could be unilateral or bilateral. It could be radiating to the buttocks, to the back of the thigh. It could be radiating to the side, to the pubic symphysis, and to the groin area. The pain will be excruciated by weight bearing. Patients will not be able to stand for so long, sit for so long, lie on that side when the patient is sleeping. Going up on the stairs with weight bearing on that leg will be very uncomfortable. But we said those tests are not very strong enough for any therapist to conclude that the patient is evidently having sacroiliac joint dysfunction. Why? Because all other pain generator in the lumbar spine could also be presented with that. So there's a need for us to go further in finding evidence of sacroiliac joint dysfunction. And what we have to do now is to move from subjective assessment to physical examination. And usually in musculoskeletal physiotherapy, our physical examination procedure is anchored on what? Observation and inspection, palpation, movement, and special test. So what are we going to observe when a patient with sacroiliac joint dysfunction is entering into our clinic? The pattern of walking, the pattern of posture will always signify that the patient is unwilling to bear weight on that side. It can be limping, it can be antalgic gait. When the patient is seated, he will shift the weight away from that side of the body. So that is based on observation. But where we really have to spend more time is on the palpation aspect. A lot of information could be derived talking about the palpation of the sacroiliac joint whenever there is a dysfunction. One of the things we can do in palpation is to ask the patients, if we are suspecting sacroiliac joint dysfunction, we're going to ask the patient to use one finger to point to the area of the pain. And this procedure is called 14-finger test. So we say use one finger to point, only one finger. Can you just use only one finger to point to the side that is giving you pain? Typically, the patient can do something like this. All right? Then we will take note of that. And then we'll say, okay, that's all right. We'll take note of that area. And then we'll allow about 5 to 10 second rest. Then we'll ask the patient again, can you again put your finger to where you are having most of your pain for the second time, please? And if the patient is able to locate the same spot, or at least 1 centimeter away from the first spot, we will be able to say that the 14-finger test on palpation is positive. It is more likely that the patient is having pain in the sacroiliac joint area. The patient will normally bring their finger very close to the posterior superior iliac spine the first time. We allow 5 to 15 second rest, and then we can ask the patient to repeat that again. If they bring their finger right to the same spot, or at least 1 centimeter close to that spot, that is correct. Okay? That is 14-finger test. Now, the other thing we can do on palpation to begin to query sacroiliac joint dysfunction would be to now go to that area where the patient pointed at, and then we'll exert a deep pressure. Exerting a deep pressure at that area could make the patient to feel a kind of pain that is similar to the original pain that the patient have in the first instance. Okay? This is 14-finger test and tenderness over the sacroiliac joint area on palpation. Another thing we can do on palpation, another test that will be carried out on palpation is what is called a Gillette test. It is called a Gillette test. And basically, what Gillette test involves is to find the 2 posterior superior iliac spine, the 2 dimples at the back. If Yusuf is having sacroiliac joint pain or dysfunction on the right side, for example, I will locate the 2 posterior iliac spine and put my thumb in it very lightly. Okay? Then I'll move this one from the left because the pain is on this side. I'll put it on the spinous process of S2 because the posterior superior iliac spine is on X2. Then if Yusuf is stable enough, can you put your hand on the support, Yusuf, so that you don't lose your balance? Now lift up the right leg. Bend your left knee and your left hip. Move it up. No. Stand straight. Move your right knee up now, up toward your tummy. See what we are having here. Can you see my fingers? We're going to repeat that test in a short while. Put your leg down. We're going to repeat it again. We put our 2 fingers on the posterior superior iliac spine to start with, very lightly. Keep the thumb on the affected side on the posterior superior iliac spine, and move the thumb on the other side to the X2 spinous process, just like this. Then you ask the patient to bend his knee and take his knee towards his abdomen. Can you see what is happening here? My thumb on the affected side is going up. Normally, it should come down. It should normally come down or stay. It should come down a little bit or stay on both sides. It should stay on both sides. So if it refuses to stay on both sides, if it comes down a little, it is a sign of hypomobility. If it goes up a little bit more than the thumb at the middle, is a sign of hypermobility. So whether it is hypomobility or hypermobility, that is an indication of sacroiliac joint dysfunction. Okay? Another test we can do on palpation, apart from Gillette test, is to do what is known as a standing flexion test. All these are palpation tests. In standing flexion test, again, we put the 2 hands on the posterior superior iliac spine. Put your hands on your thigh, Yusuf, on the front of your thigh, front. Now just bend over, keep going, and then we'll watch the thumb moving. What do you notice here again? Right? Come back a bit. Now, I think we need to explain something before we demonstrate this test. We need to explain how it works with standing flexion test using sacroiliac joint. Now, please focus here. This is sacroiliac joint again. We've got the sacrum here. We've got the ilium here. The posterior superior iliac spine is attached to the ilium. All right? Now, by the time we ask the patient to do a standing forward flexion test, the patient will go like this. The patient will bend over like this, carrying the ilium with it. If the patient is having hypomobility syndrome, the sacrum will not move, but the ilium will move. And the ilium will move in an exaggerated manner so that this posterior superior iliac spine will go higher than on the other side. Do we get that? So when we're using the standing flexion test, if there is hypomobility syndrome on the side of the pain, the sacrum can be stopped, either in nutation or counter nutation. And then when you ask the patient to bend over, the patient will bend like that. The sacrum will not move because of the hypomobility syndrome. And then the ilium will carry the posterior superior iliac spine with it and move in an exaggerated manner to compensate for the lack of movement in the sacrum. So on the side of hypomobility, we are going to expect the thumb to rise quicker and much more than the normal side. So we're going to demonstrate that on Yusuf now. So we're going to check on the 2 sacroiliac joints of Yusuf. The thumbs are on the posterior superior iliac spine. So Yusuf bend gently over in the midline. Just go on the midline. What did we notice? What did we notice? Again, we noticed that on the right side, the thumb moved a lot more than on the left side. The probable explanation, come back Yusuf, the probable explanation again is to say that the posterior superior iliac spine is moving faster with ilium and the sacrum is stopped, either in nutation or counter nutation. Okay? That must be in reference to the side of the pain. Okay? So when we notice the thumb on the side of the pain moving much more higher than the thumb on the good side, it could be a sign of hypomobility, which could be an indication for manipulative thrust in order to free the hypomobile joint. So that is standing flexion test. Now, besides standing flexion test, still part of the test we do with palpation, we can do sitting flexion test. Yusuf, come and sit down back to me. No, you're gonna face the wall there and move a lot closer to me. Just keep this one up here. Okay. So in sitting flexion test, it's more or less sit upright with the chest out, a little chest out. It is more or less a repetition of the standing flexion test. Yeah, I got it now. It's more or less a repetition of the standing flexion test, but this time around in a seated position. The two thumbs are still on the posterior superior iliac spine, and we're going to instruct the patient to bend forward in the midline. Bend forward in the midline, and we watch the movement of the thumb. You will notice again that the right thumb is moving higher than the left. So if Yusuf complain of pain on the right hand side, and the thumb on that side is moving higher than the left, the conclusion could be that there is sacroiliac joint hypomobility, whereby the sacrum is stopped, and then the ilium and the posterior superior iliac spine is compensating for the lack of movement of sacrum by moving higher and faster. So when you notice the thumb on the side of the pain moving higher than the thumb on the other side, it could be a sign of sacroiliac joint dysfunction, or what we call sacroiliac joint torsion. But how do we know whether the sacrum is stopped in flexion, whether it is stopped in nutation or counter nutation? Because that is very important as well. We need to know whether it is stopped in nutation, the kind of manipulative thrust that the patient will need. Now come to upright position, Yusuf. In order to know whether the sacrum is stopped in nutation or counter nutation, what we have to do again, identify the posterior superior iliac spine. You can go to the superior margin of the posterior superior iliac spine. You follow my thumb here. Then you move that thumb superior medially, and you get into the sacral sulcus on this side. And you have to do the same thing on this side again. Identify the inferior end of the posterior superior iliac spine. Move superior medially, and your hand will land on the sulcus of the sacroiliac joint. Now push your thumb inwardly into both of them. You will notice that one thumb is moving more anteriorly than the other. Like in this case, this thumb on the right hand side is moving anteriorly. I feel that the sulcus here is deeper, whereas the sulcus here is shallower. In most situations, when the sulcus is deeper, it is an indication that the sacrum is stopped in nutation. Okay? And when the sulcus is shallower or is more posterior, like on the left, it is an indication that the sacrum is stopped in counter nutation. So if there's any problem with Yusuf right hand side, we can deduce hypomobility. We can deduce that this right sacroiliac joint is having a sacrum that is stopped in nutated position. Okay? Thank you. Palpation test in follow-up to the subjective assessment. But how strong are these palpation tests in terms of evidence, in terms of assurance that the patient is really having sacroiliac joint dysfunction? A lot of them has varying ranges of specificity and sensitivity. Sensitivity of a test has to do with the ability of the test to detect people that truly have that condition. Specificity has to do with the ability of the test to rule out those that don't have it. Many of these palpation tests are very low in sensitivity and specificity. So there is a problem with them. They have a questionable strength of evidence. In terms of strength of evidence, for them to be able to clinically diagnose sacroiliac joint dysfunction, their strength of evidence is highly questionable. So we cannot depend on them. Just like we cannot depend on the fact from the subjective assessment. But at least the palpation tests are useful in one sense. Apart from pointing to us that the sacroiliac joint might be in trouble, They could also tell us whether there is hypomobility or hypermobility, and this information will be useful for us to know whether we are supposed to do manipulative thrust or we could just do spinal stabilization exercise if there is hypermobility, or do manipulative thrust that we have shown in one of our videos if there is hypomobility. If we suspect hypomobility, we can do manipulative thrust. If we suspect hypermobility, then core stability exercise, the use of corsets, muscle energy technique will be the treatment of choice. Now, but because of the problem associated with the evidence using this palpation test, it also means that we still have to continue to search for a better test in terms of evidence in order to diagnose sacroiliac joint dysfunction. And this time around, we will be looking at some provocative tests, which we are going to discuss in our next video.